Good evening, everyone, and thank you for joining us for tonight's clinical webcast, Everything You Need to Know About Keratoconus from A to D, the new ABCD progression and cross-linking efficacy display. Please notice that you have a text box on the right side of your screen where you can type in questions. Feel free to send in your questions during or immediately after the presentation, and we will conclude tonight's webinar with a Q&A. It's a pleasure to introduce tonight's speaker, Dr. Michael Belin. Dr. Belin is a professor of ophthalmology and vision science at the University of Arizona, Tucson. He has authored hundreds of publications and lectured extensively on refractive surgery, corneal disease, and the applications of elevation-based tomography. For his work, Dr. Belin has received several awards over the years, including the American Academy of Ophthalmology's Honor Award, their Senior Honor Award, and the Lifetime Achievement Award. As a consultant for OCULUS, Dr. Belin worked to develop the Belin-Ambrosio display, which takes numerous data points measured by the Pinacam and makes them intuitive and efficient to interpret. Tonight, Dr. Belin is here to discuss the exciting new software soon to be released on the Pinacam, and I'm sure it will be just as useful for the clinician as the Belin-Ambrosio display. So without further delay, I would like to welcome Dr. Michael Belin.
Thank you. Thank you again for everyone who's listening in. What I'm going to be doing today is actually backing up quite a bit. I always like to start with a little background. From the background, we're going to go into a little bit about the Belin-Ambrosio display, because that really is the derivation of how we develop the ABCD, go into the classification and end with the progression and efficacy display, which, as you heard, is either soon to be released. Actually, I was told I think it is currently released, but if not, it will be very, very shortly. So again, I always like to start with a little background, and again, is in order to understand exactly what we're doing, we need to really understand how tomography, in this case, how elevation differs from curvature, and why we really talk about elevation. Well, curvature, and this is curvature, whether it's produced from a Placido, whether it's produced from Scheimpflug, whether it's produced from OCT, curvature itself has some limitations. And I say it's almost analogous to measuring the spectacle power of a lens. It's very accurate. If I give the same lens to different people and put them in a lensometer, I'm likely to get the same reading, but it really tells us absolutely nothing about the shape of the lens. If you look at the picture on the lower right, you can see I can design multiple different lenses with different shapes that would give me the same spectacle lens power. Well, the same is actually true of curvature. In addition, not only I can have multiple shapes giving me different, quote, lens power, but the same lens can give different power if it's oriented differently. And we all know that, especially if you have an astigmatic spectacle, if you tilt your lens, you'll actually induce a different astigmatic power. So again, power and curvature are very similar. The problem with that is, again, that there can be multiple shapes to give you the same power, and tilting, or in this case in the human eye and those angle kappa, could induce what looks like changes in curvature when the shape is actually all normal. And these two maps, if I show you these two maps, you would think they are extremely different. The upper left looks like a symmetric astigmatic eye. The one on the right looks like highly asymmetric inferior steepening that almost everyone would call keratoconic. And these two maps are produced from the identical shape. This is actually an astigmatic test object. The one on the left is 0 degrees angle kappa. The one on the right is 5 degrees, which is considered the upper limit of physiologic normal. So the exact same shape, but completely different curvature maps. And that's one of the problems with curvature. Now, as I said, angle kappa is, it's not exactly technically angle kappa, but it's the angle between the pupillary and the visual axis, and displacement up to 5 degrees is considered normal and physiologic. And if you think about when we used, way back in training, when we used to examine infants and we did a Hirschberg test, which is just a light reflex test, we had patients with what's called pseudostrabismus. And when you reflected light, they looked like they were crooked, but when you did cover or uncover, they were straight. Well, the Placido is effectively a light reflex test. And that infant who was effectively ortho but looked crooked on a Hirschberg would grow up to have an abnormal looking Placido map, but a completely normal eye. The advantage of elevation, and again, whether it's produced from Scheimpflug, optical cross-sectioning, OCT, is that it's elevation-based and not curvature-based. And this is a cross-sectional image of a Scheimpflug. You can see the image detection, which shows the anterior cornea. Yeah, my pointer shows the posterior cornea here, the anterior lens. And though often you can't normally see this unless you dilate the eye, which this is obviously a very dilated eye, the posterior cornea. If you can measure all these surfaces, you can then measure corneal thickness throughout the cornea. So you get a corneal thickness map. You can measure anterior chamber depth, lens thicknesses. You can see here, you can actually also measure the density of the lens. Now, if you can measure elevation, if your elevation is accurate, then you can also produce curvature, because curvature is the second derivative of elevation. And as I showed you on the prior picture, if you can measure the anterior surface and the posterior surface, you can produce a corneal thickness map, because corneal thickness is just a spatial difference between the anterior and posterior cornea. So again, if you have accurate elevation, you can produce any of the curvature maps, whether it's axial or tangential. You can produce elevations from the front and the back. You can produce a corneal thickness map. Curvature cannot do that. Though a number of devices that measure curvature try to produce elevation, the only way they can do that is by making certain assumptions about the shape of the eye. And those assumptions actually don't work well in abnormal eyes and actually fall completely apart in eyes that, let's say, keratoconic or post-refractive. For those of you who remember your calculus, curvature is a second derivative of elevation. There's only one solution, but to go from curvature to elevation, it's an integral, and that has multiple solutions. So that's one of the reasons we really rely on elevation. And then the question is, how do we display elevation to make it somewhat intuitive for the user? And there are multiple different ways you can display elevation. However, the most common is to display it against a reference surface, and the most common reference surface is a best fit sphere. For almost all our displays, we use the best fit sphere taken from the central 8mm zone. Here you can see if you have an astigmatic cornea, the flat meridian rises above the best fit sphere, the steep meridian falls below the best fit sphere, and if you have a regular astigmatic cornea, this is a type of elevation map you would see, where again, this is the steep meridian and this is the flat meridian. The picture on your left here is a normal astigmatic pattern. Very often people will send maps and be concerned about these numbers and say, is this abnormal? I have a plus 26 over here. The first thing you should ever do when you look at an elevation map is look at the pattern. If the pattern is normal, and this is a normal astigmatic pattern, these numbers in themselves only indicate two things. One is the amount of the astigmatism. The higher the astigmatism, the greater the separation between the steep and flat meridian. And two, how far it is from the apex. You'll notice if I go along the steep meridian here, you'll see the numbers increase as I go further out. And if I look at this meridian, sorry, the steep meridian here, you'll see the numbers decrease as I go along here. So the further I go from the apex, the greater the separation between the steep and the flat. Again, this is the flat. I said it incorrectly before. This is the flat meridian because it's raised above the best fit sphere. This is the steep meridian. So these numbers in magnitude don't indicate pathology. They indicate distance from the apex and the magnitude of the astigmatism. Compare this picture to this picture. We call this a positive island of elevation against a sea of blue. This is obviously distinctly different than this astigmatic pattern. This is what we look for when we're looking for ectatic disease. This is a positive island of elevation surrounded by a sea of blue. Now, I explained earlier why we get this pattern for an astigmatic eye. Again, this is the two meridians. You can see the flat meridian raised above, the steep meridian below, as you can see here. But why do we get this type of pattern in an astigmatic cornea? Well, if you think of just of a cone, and obviously no eye is shaped like a cone, but if you think of a cone and try to fit a best fit sphere to that cone, look what happens. The best fit sphere truncates the top of the cone, which is above the best fit sphere, all positive. There's a sharp area of transition from positive above the best fit to below, that little rim of green here. And then as we go further out, we get into a negative or blue zone. But notice where the deepest area is. It's not in the far periphery. It's in the mid-periphery right here. And notice that's exactly what we see here. So this is why we get this type of pattern in an ectatic cornea. Now I'm going to back up just a second. Realize this is actually from an eye, but you'll almost never see a pure cone looking like this, because almost all keratoconic corneas also have significant astigmatism. So we look for these positive islands usually superimposed on an astigmatic pattern. The other major benefit of optical cross-section with Scheimpflug imaging is the ability to see the posterior cornea. As many of you probably know now, the posterior cornea is probably the earliest indicator of ectatic change. So here's an example showing the advantage of complete optical cross-sectioning, identifying both the anterior, posterior, and corneal thickness map. If you look at the anterior elevation here, it is a normal astigmatic pattern of relatively low astigmatism. If you look at the curvature map, it's fairly normal, but notice what you see on the posterior cornea, a positive island of elevation superimposed on an astigmatic pattern. This is abnormal. This is an eye that is ectatic in spite of the fact that the anterior surface is normal and vision is normal. Notice that the ectatic region has caused a displacement in the thinnest point, coinciding with the posterior ectasia. Here is another example. Here is the anterior surface, though you get a hint of a very early island. If you look at the curvature map, it looks normal. But notice again the posterior cornea, a prominent posterior ectasia superimposed on an astigmatic pattern. So again, the value of looking at the posterior surface is that it is usually the first indicator of ectatic change. Another example, again, if you look at the curvature, sagittal curvature map, it looks absolutely normal, relatively low amount of astigmatism. The anterior elevation is normal, but again, look at the posterior ectasia. So why do we say we use a best fit sphere? The reference surface doesn't affect accuracy. A sphere is not any more accurate than any other reference shape. It only affects the appearance of the map. But if you want to use normal values, then you have to keep your reference surfaces constant. So this is just a quick comparison. The reason we use a best fit sphere is because, one, it's the easiest to interpret, the most intuitive, and as you can see, it actually makes visual inspection the easiest. So this is a series of patients with markedly advanced keratoconus. So these aren't patients that have just mild disease. You can see a big prominent anterior ectasia, prominent posterior ectasia, a markedly thin cornea, and a grossly abnormal pachymetric progression. And what we've done here is we showed you how this the back surface looks like with a sphere, how the back surface looks like with a best fit ellipse, a best fit toric ellipse, sorry, a fixed ellipsoid and a toric ellipsoid. And what you can see here is obviously that the sphere visually is the most easy to interpret. Here's another example. Again, sphere versus ellipsoid versus toric ellipsoid fixed versus toric ellipsoid. And again, while you can identify it here and here, you'll notice it is much easier to identify the ectatic region with the best fit sphere. So is the best fit sphere the best reference surface? And as I alluded to earlier, the reference surface just changes the appearance. It's not inherently more, one is not inherently more accurate than the other. But in the bad display, we use something called an enhanced reference surface. We try to take the best fit sphere and improve on it. How do we do that? Well, if you consider, excuse me, a best fit sphere, and if you look at this kind of light green color here, if this is a schematic of an ectatic cornea, here's the ectatic region. This is what a best fit sphere would look like. And what we look for, again, are these positive islands of elevation, which is the area above the best fit sphere. We really would like something more like this, something that follows the more normal peripheral cornea, because if you have a shape like this, notice how much higher or easier that ectatic region would be to see. Again, if we compare this to this, that obviously would be easier for us to see. Well, is it possible for us to get some shape that more mimics the normal peripheral cornea? So what we do in the Belin Ambrosio display, we take the same 8mm optical zone that we normally use for the best fit sphere, but we take it's actually a variable 3 to 4mm zone surrounding the thinnest point, and we exclude that from computation of the best fit sphere. So what we do again is we take the same zone that we normally use for a best fit sphere, which is the central 8mm zone, but we take a small area surrounding the thinnest point, in this example, 3.5mm diameter surrounding the thinnest point, and we exclude that from the best fit sphere. The reason we take it from the thinnest point is because that represents the ectatic region of the cornea. And effectively what we do is we change this to this. And again, create this amount of elevation becomes much higher with the enhanced reference surface. Because normal eyes do not have ectatic regions, they have the eyes minimally aspheric. When we do that same computation, there is little, if any, change in the appearance of the maps. Here's a before or after. This is using the standard best fit sphere. That's the 8mm zone right here. And notice if you see this, it's an astigmatic pattern. There's a little hint of maybe a beginning of an island here, but notice what happens when we use the enhanced reference surface. That little area becomes much easier to identify. Here's another example. Again, this would be easy to identify using the standard best fit, but when we use the enhanced, notice again, we get greater elevation. The posterior surface would be easy to identify with the standard best fit sphere, but again, the elevation becomes greater with the enhanced reference surface. Just as important as accentuating abnormal ectatic regions, we don't want to create abnormalities in eyes that are normal. And when we look at a normal eye with the standard best fit sphere and the enhanced, it basically doesn't change. And this is the back surface. Again, basically, they look the same. When we compared a large number of patients, both normal and keratoconic, what we found was that normal eyes showed an average change of less than 2 microns, going from the standard 8mm best fit sphere to the enhanced reference surface, while keratoconic eyes showed over a 20 micron elevation change on the anterior surface. On the posterior surface, normalized underwent less than 3 micron change, and keratoconic eyes underwent greater than a 40 micron change. This is easier to look at, or at least easier to see in a bar graph. So you can see the change going from best fit sphere to enhanced reference surface. That change becomes very useful in separating normal eyes from keratoconic eyes, because keratoconic eyes undergo dramatically more change than normal eyes to a p-factor of 0.0001. That is actually the derivation of the left part of the Belin-Ambrosio display. The right part works with pachymetric data. The left part works with anterior and posterior elevation data. And as many of you know who are familiar with the Belin-Ambrosio display, we actually report now there are 9 different parameters in the regression analysis, but the DF value is that change in elevation going from best fit to enhanced reference surface. The DB, which is DF, is the change of the front. DB is change in the back, is the posterior elevation change. Again, there are a number of other parameters: pachymetric progression, thinnest point, displacement of the thinnest point, ART max, elevation at the thinnest point, a number of other parameters, all in the regression analysis. And we report all these individual parameters in standard deviations. Just by convention, we color code them if you want them color coded, that if an individual parameter changes to 1.6 standard deviations or greater, it turns yellow. If it's 2.6 standard deviations or greater, it turns red. No single individual parameter in itself has predictive ability. So I don't want anyone overreading each individual parameter. It's really the final D value, which is produced by a regression analysis of all the parameters, that is the most important. And that's one designed to have predictive value. And this is the appearance of the current display. And a lot of people think that the regression analysis, get my point back, only involves the bottom here. It doesn't. It involves all these parameters up here also. There just isn't enough room on the bottom to load everything. But you'll notice there's K1, K2, K max. This is front elevation at the thinnest point, back elevation at the thinnest point, the progression index, the Ambrosio relational thickness. These are the 2 pachymetric progressions. Here's the pachymetric map. This again is the anterior elevation. This is the posterior elevation. And then the D values, and again, the one that's predictive is the final D here. As I said already, you may have individual yellow or red, but it's really the overall D that becomes clinically important. The map is there to help you. It doesn't tell you what to do. You need to consider age, ablation depth, family history, and stability of the exam. People always ask me, and I hate to put things in writing like this, but what are my general guidelines? And these are my general refractive guidelines. General means they're not set in stone. I rarely do refractive surgery on patients less than 21 unless needed for occupational needs. In general, I do not do LASIK with thinnest pack below 495, though there's no data to support that. That's just my practice. All my computations are based on thinnest point readings, not apical readings. I haven't used ultrasound pachymetry in probably a decade. I use a minimal 300 micron residual bed, which is based on the thinnest pachymetry, and my femtosecond plus 2 standard deviations, which actually I've cut back a little bit at. I won't mention companies, but we switch femtoseconds, and the tolerance, the standard deviations on the one I'm using now seems to be much tighter. and then I used a computed ablation depth. My, again, general guidelines for LASIK, not for PRK, in patients less than 30, a final D of less than or equal to 1.6, patients 30 to 35, final D of 1.8, 35 to 40, 2.0, and greater than 40, 2.2. Patients above 55, we have little data on, and probably can be a lot more liberal, but again, we don't really have data on that. You can be more liberal on surface ablation, but at least in my practice, the number of patients getting surface is relatively small, so I don't have hard numbers for that. In summary, the BAD allows high specificity and sensitivity. I have not used a Placido device in more than a decade. You need, as I said already, you need other information to make the final decision: age, ablation depth, family history, stability, and always remember to compare both eyes for symmetry. Two normal eyes that are highly asymmetric is a red flag. Why did I go over that? Because everything now on the ABCD actually was derived from the observations we made with the BAD display. So I'm going to go into now a little bit about the ABCD classification or ABCD grading system, which has been out now for probably at least a year. In April of 2015, it's actually over 2 years ago now, there was an article in the journal Cornea, and this was actually a consensus document of the 4 multinational corneal societies: the Cornea Society, Asia Cornea, Pan Cornea, and U Cornea. So basically, this was unusual in that every single international society put together a consensus. And one of its conclusions was that we don't have an effective way of grading, classifying disease. We don't have an effective way of determining when and if progression occurs. I was part of this committee, and it kind of was my motivation to begin work on the ABCD. I also, for years, more than years, hated the Amsler-Krumeich classification. To me, it was a totally useless classification. First of all, it dates from 1947, I think. If you notice the pictures on the left, that was also from 1947. None of us use that. I don't know why we're using the thing on the right. It predated topography. It obviously predated tomography. It was based on a keratometer and an optical pachymeter. There's nothing else in medicine that is staging diseases on a 70-year-old system. You would be laughed out of an auditorium if you were in an oncology meeting and described your patient based on a 70-year-old classification. What are its limitations? One, it relies only on a single apical reading, and here's a good example. If I only had an ultrasound, this cornea would read 519 microns. It actually is 499 right over here because, again, it's completely missing the fact that the thinnest point is displaced. What's the other limitation? It completely ignores the posterior surface. This is a completely normal anterior surface. This is an ectatic posterior. This is a highly abnormal cornea that would be missed on Amsler-Krumeich. More so, it's been an impediment to us ever trying to figure out how to treat our patients, who to do rings on, who to cross-link, who to do DALK on. The reason is, here's an example. Here are 2 patients. The one on the left is an 18-year-old with a PAC of 410, a mean K of 52, and an RX of -8. The patient on the right is 47 with a PAC of 544, a mean K of 48.5, and RX of 525. These 2 patients are dramatically different. Most of us would approach these patients dramatically different. They are staged identical on Amsler-Krumeich. They're both stage 2. This is a meaningless, useless classification system. So here's my plea. Every time I hear someone at a meeting go up and say, this is how I treat patients, this is how I treat stage 2 disease, this is how I stage 3 disease, I cringe because it's meaningless. So what do we need? Well, we need something, again, this was really no different than what's being done in any other field of medicine, where how we stage disease. We need something that recognizes all the anatomical changes, the anterior surface, the posterior surface, the corneal thickness. We need relatively simple parameters. They should be platform independent, limited to, it means any tomographic device should be able to do these measurements, and the information should be relatively easy to convey. We need a system that allows us to effectively evaluate our different treatments, be it either cross-linking, rings, DALT, PK, rigid contact lenses. But again, an example would be, if you have someone with a normal anterior surface but a prominent posterior ectasia, they can have excellent vision. That's not an appropriate candidate for rings if they have good vision and normal anterior surface. We need systems that allow us to describe each anatomical layer. And the reason I went through the whole description of the bad display is because what we notice from the bad is that if we remove this 3mm zone from the best fit sphere and we take it out of the best fit computation, effectively what we do is we normalize that reference surface. The reason that works is that this exclusion zone represents the bulk of the ectatic region. So rather than removing it as we do in the bad display, let's concentrate on looking at that specific region, which is a 3mm zone centered on the thinnest point, because that represents the bulk of the ectatic region. We use radius of curvature, and again, it's not something you have to compute. The machine does this automatically instead of diopters, so I know most people are much more familiar with diopters. Diopters works fine on the anterior surface, but diopters really makes very little sense on the posterior surface because the posterior cornea is a low power minus lens. Radius of curvature is a measurement that's independent of index of refraction. So it's much easier to compare anterior and posterior surfaces. It's the same measurement. So we looked at the anterior radius of curvature at the 3mm zone, the posterior radius of curvature at the 3mm zone, and the actual thinnest point, not the apical reading, but the thinnest point of the cornea. And we came up with what we call the ABCD keratoconus classification or grading system. Without going into too much detail, stage 1, 2, 3, and 4 from the anterior surface somewhat followed the divisions in Amsler-Krumeich since people were used to that. But we added a stage 0. Reason for that, if you think about it, there is no such thing as a normal eye in Amsler-Krumeich. Everyone has stage 1, and people consider stage 1 disease. We use then the separations from the anterior surface. We determined their standard deviations, and we used those and applied them to the posterior surface. This is corneal thickness, and we added a D value, which is distance visual acuity. The machine obviously doesn't do this. The user has to enter that themselves. So we have 4 numbers, A, B, C, D. A is for the anterior surface, taken from the 3mm zone, centered on the thinnest point. B is for the back or posterior radius of curvature, taken from the 3mm zone, centered on the thinnest point. C is the thinnest corneal reading, and D is distance visual acuity. Currently, it's part of the Topometric keratoconus staging system. As I said, this has been available for, I think, over a year, and this is a blow-up of what the display looks like. The actual description would really be here. In other words, this is exactly the radius of curvature of the anterior surface 3mm zone, the posterior radius of curvature 3mm zone at the thinnest pachymetry, and this is the distance visual acuity. These are the A, B, C, D values, and then this is the actual classification here. This is a good example of the value of this. A0 tells you you have a normal anterior surface. If you have a normal anterior surface, notice your distance visual acuity is normal. But notice you have a big posterior ectasia and a fairly thin cornea, A0, B4, C3, D0. Again, the machine does this automatically for you. The advantage of this is that you can now look at these type of patients and do studies to determine what's an effective treatment. Calling this patient, in this case, stage 1 on Amsler-Krumeich, tells you nothing really about the eye. Let's look at some examples. Here is a normal eye. You can see here's the standard refractive display, a completely normal looking eye. Here's the topometric keratoconic staging, and I just blew up the staging here, and you can see again that everything is completely normal. Here is an eye with very early ectatic change. Here's the anterior curvature. Notice there's a very hint of a positive island here. There's a little bit more of a hint of a posterior island here. And notice when we come down to the staging, it's A1, B0, C0, D1, a very slight change in the anterior surface, a little change in vision. But if you notice, B is just below level to be abnormal. So this would be an eye that would be suspicious for you to watch. Here's an eye with moderately advanced keratoconus. I think no one would really miss it, but notice the ABCD classification. A2, B4, again, a much larger posterior ectasia than anterior ectasia, but the cornea is not that thin, 470, it's only 1.4. And because, again, we have significant changes in the anterior surface, vision is significantly reduced. A2, B4, again, moderate change in the anterior surface, marked change in the posterior surface, minimal corneal thinning, but significant decrease in visual acuity. And finally, advanced keratoconus. Again, you can see here, we're A4, B4, C2, and D2. Again, you can see the topometric keratoconic staging and obvious keratoconus here. But again, this allows an anatomical description of each layer and a description of the visual acuity. The real goal of developing that wasn't just classification and staging. It was really to develop a progression display. For those of you who are just getting into cross-linking, and for those of you who might be international, the biggest question always is, when do you treat? And who do you treat? And when and if, how do you know if progression occurs? So the reason we developed this again is that we now have the ABCD, in this case really just the ABC for progression. And we have different parameters describing each anatomical layer. To determine whether we've had significant change, we have to determine determine the background noise for each of these parameters. So we studied actually two populations. We studied both a normal population and a keratoconic population. And the reason that we did that is that for patients with more established disease, the keratoconic population, in this case, the noise level of a keratoconic measurement is probably more appropriate. But if you have a young patient with very early disease, that measurement noise more closely mimics a normal population. If you have, again, let's say a patient with subclinical disease, this very early change, that measurement probably has less noise and probably is closer aligned to a normal population. So we looked at both. And what we did is we developed basically what is a confidence interval for significant change. So we looked at, again, the anterior radius of curvature, looked at the posterior radius of curvature, and the minimal corneal thickness reading. And we looked at what we call one-tailed confidence intervals. The reason we did one-tailed confidence intervals is because we're actually only concerned about measurement in one direction, either steepening or thinning. If a cornea thickens, we're not concerned. If the cornea flattens, we're not concerned. So we looked at one-sided confidence intervals, and we looked at two confidence intervals, an 80% and a 95%. No magic reason we chose those numbers. We just wanted to allow the user to have flexibility to basically determine on their own what level of risk aversion that they have. And this is what the display looks like. It looks confusing. It's actually fairly simple, and let me explain it all. This first area here represents exams over time for the anterior rays of curvature from the 3 mm zone. The second bar series here represents the posterior rays of curvature. The third series represents, you can see here, A, B, C, D, represents the thinnest pachymetry, and this represents distance visual acuity. The display will show up to 8 exams over time. So you can see here, May of 06, June, September, March of 07, May of 08. So these are a number of exams over time. The user will identify the baseline exam, and that obviously shows here as BE. You also have the ability to indicate whether you've treated the patient. In this case, usually we're talking about cross-linking. And you can see here, there's a treatment, you can check it off, and that treatment will show up as this crosshatch here. So again, here we will show up to 8 exams over time. You can identify your baseline exam, and you can identify when and if treatment was done. These 4 color lines represent the different confidence intervals. The green hatch is an 80% confidence interval in a normal population. The solid green represents a 95% confidence interval in a normal population. The red hatch is an 80% confidence interval in a keratoconic, and the solid red is a 95. So you can see in this patient from a relatively short period of time had a statistically significant change on the anterior surface, a statistical change in the posterior surface to the 80% level, and a highly statistically significant change on corneal thickness. Patient underwent treatment and actually did very well. In addition to the ABCD parameters, we also, in a tabular form, show a number of other parameters. We show the final D values, the progression index, ART max, K max, Q values, and then the number of the anterior curvature parameters that some people like to look at. And then at the bottom, we actually show you the ABCD classification. So again, this is just a blow up of the additional parameters. We only graphically display the ABCD, but we do allow you to follow a number of other parameters if you would like to. Here is an unusual case. This is actually from an article we just recently submitted of what appears to be documented true unilateral disease. This is the involved eye. First of all, you can see the involved eye undergoing significant change, and this is over a 4-year period, and this is the normal eye being completely stable. So again, here's another example from that same paper of unilateral keratoconus. This is the example that I think in itself should speak for the validity of this display and the importance of the ABCD classification. This is a patient that many of us who cross-link, this is a so-called, I don't want to call it normal, but call it an eye with normal, completely normal vision, and the patient thought to have highly asymmetric keratoconus. This is the normal eye. So if we look back in November of 2013, notice the ABCD classification, A0, B0, C0, D0. Patient was totally asymptomatic, had excellent visual acuity. This patient was observed over time, and the patient didn't have a change on the anterior surface until 2017. But if we, and I should go over, one of the benefits of the progression display is that it can be retrospectively used. So your old exams can be automatically analyzed. So this is a patient that we went back and looked at. So this is a patient that has been followed for 4 years and ended up getting treated, but they already had mild decrease of vision. Had this patient benefited from the progression display, notice even at that second exam, there was statistically significant change, even though they remained, quote, normal on the anterior surface. They went from A0, B0, C0, D0 to A0, B1. Their vision was normal. They changed. They should have been cross-linked or treated here and preserved their vision. But looking only on the anterior surface and not having, again, tomographic parameters to determine progression, their treatment was delayed till 2017. It was still caught early, but they already had decreased vision. This example alone should really speak to the importance of carefully following the patients, following them tomographically, and determining not when vision changes, but when statistically significant changes occur on any anatomical surface. Again, I think this is a great example of the value of the display. So what's new in the diagnosis and progression monitoring? Again, a tomographic-based classification system that recognizes all the anatomical layers, a tomographic-based progression display that documents statistically significant change and also allows you to document cross-linking efficacy. Thank you.
Thank you, Dr. Belin. We do have some questions, so if you don't mind sticking around for a few questions here. Let me start at the top. And by the way, just to remind everybody, you do have a questions text box. If you have any questions about the discussion, then you can put those in there, and then I will get them to Dr. Belin. So, Dr. Belin, the first question here, what is the best way to screen potential ectasia in pre-LASIK patients using the Pinacam? And then I'm going to combine that with another question. Should you use the ABCD staging as a tool for screening for refractive surgery?
Very good question. I actually didn't go over that. People always go, well, why do you need all three displays? They're actually very different. The Belin Ambrosio is designed for refractive screening. It's designed to separate normal from abnormal. It doesn't specifically describe the abnormality. It's really meant to give you a very easy way to screen patients. It is basically, I don't want to say, again, I don't want to say it's all I ever use, but really it's what I use to screen my refractive patients. If I have, once someone fails, then you work the person up, and that's very different. The ABCD is exactly what it's called. It's a grading or classification. It describes the anatomical regions of the cornea. It's true the Belin Ambrosio display can be used somewhat to diagnose keratoconus by looking at the final D value, but any abnormal eye from other pathologies will also give you abnormalities on the Belin Ambrosio. Again, it's designed to separate normal from abnormal. The classification really is designed for studies. I'm part of this group that meets every year at ESCRS, and for 5 years they've been trying to determine what's the best treatment for different types of keratoconus. And that's what I was kind of alluding to about Amsler-Krumeich. You can't ever figure this out if you're using a system that classifies those two divergent examples that I showed, that 18-year-old and the 47-year-old, and calls them the same. So the ABCD was really designed in response to the consensus document and the fact that we have no real guidelines about who should get what treatments because our system is outdated. The progression display is exactly what it is. It's to allow you to see when you have statistically significant change. And to me, probably would become one of the most valuable tools in determining when and if patients should be treated. So they're all related, but they're all different.
Next question here is, how do we make sure curvature asymmetry is due to a large angle kappa?
The biggest thing is, right off the bat, is to look at the principal meridians on the curvature map. And no matter how abnormal or asymmetric it looks, if the principal meridians are orthogonal, it is highly likely due to, it's not technically an angle kappa or whatever, but it's highly likely, I call it a displaced apex. You can also look at the elevation map, and the elevation map will look displaced, but will have a normal astigmatic pattern.
Now, this is another question from the same attendee. Should we always center treatment based on angle kappa?
Can't answer that. That's an individual surgeon preference. It also will at times vary between machines and ablation patterns, and whether you're doing, each machine has different, like Wavelight has contour, has different, so you can't answer that for any specific. It's just.
Can you do the ABCD analysis using the data obtained before? If so, how?
Yeah, it automatically, your old data will automatically enter into it. That's one of the nice things about it, particularly with the progression display. Your old files will work fine. So if you have patients you followed for many, many years, and you call up the progression display or the ABCD display, it will enter in. And the machine, again, many of you haven't received the progression display, and it may not again be officially out yet, though it should be in a matter of days. The machine self-populates. You can select if you want to exclude any, but the machine, so if you have 6 different exams over time, the display will self-populate with those 6 sequentially.
I think this is based on one of the slides where you were showing the ABCD staging, and then I think that there, outside of the ABCD, there was a column there for scarring. Is there, or will there be a place to grade the corneal scarring?
No, it was put in just as a descriptor, but it's not something that the machine does, or so the answer is no.
Last question here, and I know that you discussed it a little bit during your lecture, but do you have any guidelines on when you would use the pathological population versus the normal population, or when you would use the 85% mark versus the 90% mark? And I think they meant the 80% or 95%, yeah.
We purposely want to give the surgeon a lot of flexibility. I hate when, I know, and to some degree, the bad display has become something like this, where we kind of say, well, I'm not doing it because the D value is this. The decision whether to treat someone, whether it's cross-linker or anything else, really is a discussion between the surgeon and the patient, and the risk aversion of the patient. So we try to give you different guidelines, really. If I had a patient with established keratoconus that was, let's say, clinically evident, easy to pick up on even a keratometer, and the patient was, let's say, in their mid-20s or later, I would probably use the keratoconic database. But if you have someone with early disease, or someone probably in 25 or less, I personally would be a little more aggressive in treating those patients. But again, that's a surgeon and patient discussion. And we specifically wanted to give you as much data as possible so you can discuss, again, the risks and benefits. Clearly, you know, cross-linking is safe, but is not without some complications. So It's a discussion that you have to have with the patient.
Now, is this system useful for classification and monitoring post-LASIK ectasia?
Which system? I don't know which system they're asking.
The question specifically says, can we use this classification system to help diagnose / monitor post-LASIK ectasia?
Well, two things. You can use the progression display to monitor post-LASIK ectasia, but I will give you my opinion. Post-LASIK ectasia, by definition, is progressive disease. So yes, you can follow it, but it is a progressive disease because you started from, unless the patient had keratoconus pigmentosa, if you started with an eye that was so-called normal before LASIK and has post-LASIK ectasia, they by definition have progressive disease. But yes, you can monitor the patient with the progression display.
Okay, and that's it for questions. So thank you, Dr. Belin. Again, always a pleasure.
Want to thank everyone for staying on, and have a good evening. Take care.
You too. And if anybody joined us late, you can go to our website, and we'll have this lecture posted on our website within a couple weeks. We also have lectures, live lectures on our Oculus TV website. Also, you can see there on the screen. And then if you have any general questions about the Pentacam or any of the other Oculus diagnostic devices, you can reach us at the 1-800 number shown here, or the email sales@oculususa.com. So thank you again, Dr. Belin, and thank you everybody that's in attendance. Have a good night.